That will be good, and it should be pretty painless. You can complete it in less than 30 seconds. With that, let me pull up our guest speaker this morning is Dr. Nathan Price, who drove up this morning from Tucson to talk with us. He is the Associate Professor of Pediatrics in the Division of Infectious Diseases at Banner University Medical Center in Tucson. Dr. Price grew up in Tucson, Arizona, and completed medical school and pediatric residency at the University of Arizona. He then went on to do pediatric infectious disease fellowship at the University of Alabama at Birmingham, and then practiced in Iowa City for a while before he returned home to Tucson, where he practices at Banner University Medical Center. He's interested in congenital infections, coccidiomycosis, and antimicrobial stewardship. And when he's not at work, he and his wife spend most of their time chasing their 4 children around that town. So without anything further, Dr. Price, take it away.
Well, thank you, and thanks for inviting me to be here. I'm excited about this topic, and hopefully you guys will find something interesting about it. So I've done some consulting. We won't be talking about anything related to that today. And our objectives today basically is we're going to be talking about mosquitoes that are around here, some of the mosquito-borne illnesses that may be around here, and some of the things that people may bring back from their travels, and then talk about what we can do to try to prevent problems associated with that. So just want to talk a little bit about some history. It wasn't until relatively recently that people figured out that mosquitoes actually transmit infection. And the way they figured this out was with the disease of yellow fever. And you may not know this, but yellow fever used to actually be here in North America. When you think about yellow fever these days, you're usually thinking about places like Africa and tropical areas. But they used to have yellow fever that would come through and cause lots of problems. And it had really quite a high fatality rate. And back then, people thought that these miasmas, these like maybe clouds of bad air, would have the thing that caused the disease. And in fact, malaria is malaria, which is thought to be malaria, bad air, basically. So back in the 1790s, Benjamin Rush, who the Rush Medical School is named after, was a physician in Philadelphia when a big outbreak of yellow fever came through. And he noticed that there wasn't really person-to-person transmission like some of the other infections that was happening, but he thought maybe there was some sort of intermediary that was happening. Again, it was probably in their mind this bad air. He noted, though, that during that time, there seemed to be more mosquitoes in the area than typical. And he wrote that down in his journals. Well, as another interesting tidbit, Napoleon put down a rebellion in the Caribbean, and he lost 40,000 soldiers to yellow fever. So a big deal. And interestingly enough, within about a year or so, he sells the Louisiana Territory to the United States. And so I wonder if all that death and swamp and badness played a role in that. So then the U.S. started to be interested in Cuba, and Carlos Finlay was in Cuba, and he starts looking through Benjamin Rush's journals and sees that there's this mention of mosquitoes, and that kind of triggers the thought of maybe the mosquitoes are this intermediary of transmitting infection. And he puts out this theory, and he actually starts getting some evidence that this is the case. And, you know, like a lot of new ideas, it's not well accepted. He just gets completely laughed to scorn by the medical community. And so the U.S. invades Cuba, and for every soldier that dies from actual battle, they lose 13 to yellow fever. And so the U.S. military really becomes interested in yellow fever and what they can do to try to prevent that. And so Walter Reed is tasked with trying to figure out what's causing yellow fever and what can they do to do it. And he is able to, with his group, really be able to figure out that mosquitoes are transmitting yellow fever. In fact, while he was away, people in his group actually let mosquitoes that had fed on people with yellow fever feed on them. And one of the people actually died because of it that was in his group. Well, he comes back and he does this experiment where on one side, they have this area where it's got all the cast-offs from people who had yellow fever. And yellow fever is an awful disease. You vomit blood, you have diarrhea, you have all kinds of secretions that in theory, like other diseases, might be infectious. And so what they did is they stuck people in a room that were otherwise healthy that had these fomites, basically, of people who had yellow fever, but there were no mosquitoes in that part. In the other area, they had a totally clean area, but had filled it up with mosquitoes who had fed on people who had yellow fever. And lo and behold, the people with the dirty stuff with no mosquitoes didn't get yellow fever, and the people with the clean stuff that had the mosquitoes got yellow fever. And so he was really able to prove that. And again, it took a long time for people to figure this out. Cuba had figured this out sooner because of Carlos Finlay, and they had gotten rid of yellow fever a lot quicker than the US finally got around to getting rid of it. So that was really where people started to see that mosquitoes are a problem. And you may not know this either, but there used to be a lot of malaria here in the United States. And you can see here in this map back in the 1880s where malaria was. And then as time goes on, people again figured out mosquitoes are a problem and started doing things to get rid of mosquitoes. And little by little, malaria started receding from it. There is actually malaria here in Arizona. Walter Reed, that same person who figured out mosquitoes, before he figured that out, he was stationed at Fort Lowell near Tucson and was dealing with the malaria outbreak. And there are other places like Wickenburg and Obed that were towns here in Arizona that were having malaria outbreaks as time went on. Interestingly enough, Obed, you probably don't recognize, I had to look this up, doesn't exist anymore, and partly because it was hard to live there, and partly because a lot of people died because of mosquito-borne illness. So other things have been through the US that we don't tend to think about here in the US. For example, dengue used to come through and enter in to places of travel and then spread around places of travel as that virus would then get into the mosquito pools in those areas. And so as you looked at the transcontinental railroad at these stops, you would start to see these diseases spread through. So the mosquito is the deadliest animal ever. It's said to kill more people than all the wars combined, and they think that 1 million people die every year because of mosquito-borne illnesses. There are lots of mosquitoes out there, thousands. And in Arizona, we have 200, or excuse me, in the US, we have 200 different species, and there's 46 species here in Arizona. The good news is that most of these are nuisance mosquitoes and don't tend to transmit disease. When you look at what's going on with the mosquitoes, they have, their life cycle where they lay the eggs, they turn into larvae, they go through the pupa and then turn into the adult, and then they feed. Most mosquitoes just feed on nectars and fruit juices. It's the female mosquito that actually feeds on humans because it needs that blood meal in order to produce the eggs. And you can see here that it really does not need a lot of water. This is just a little bottle cap full of larvae. And so it's easy for these guys to replicate and cause trouble. When the female mosquito feeds on a human, what it does is you can see here that this is actually a diagram of the proboscis. The proboscis is not just one little thing that sticks into you, it's 6 pieces. The outer edge has these little saws on it that will saw through the skin and open the skin. And the other 2 pull the skin apart, and you've got one that sucks the blood out and the other that injects the saliva that has anticoagulants to keep things flowing. And so there's not actually any mixing of blood. And that's one of the reasons why things like HIV aren't getting transmitted. But it's through that injection of saliva that these other viruses and parasites have evolved to be able to get into the person. And so as it's sucking blood out, the saliva is getting injected in, and that's when these viruses get injected into the host. So mosquitoes, like I mentioned, just need a little bit of water. And so there's all kinds of places where this can happen. And this is just a diagram that the Arizona Department of Health Services put out to make people aware of where mosquitoes can occur. And so they just need a tiny little bit of water. And this can happen all over the place in our yards, in our homes, and in the community. And you can see down here that there's this little set of toys. This really hits home for me because about 2 years ago, and it's probably longer because my kids are older, we used to have this little water table with toys that looked literally just like that. And it had a cover. And one year I was neglectful and didn't put the cover over, and it was the rainy season. And I walked out about 2 weeks later and pulled it off, and there was about 1 inch of water in there, and this whole cloud of mosquitoes just moved around. And so again, it's easy for these guys to be in your area. And if they're nearby you, they're going to bite you.
How long does this standing water need to be there?
I don't think it needs to be longer than a couple of days to a week. I forget what the life cycle is, but I think it's pretty quick that they get through. But I don't know the real answer to that. But the water I had only been there for a couple of weeks, so it doesn't take long. So when we look at the mosquitoes, there's a whole variability in which mosquitoes there are and what they do. So different habitats, different places. Some of them bite at night. Some of them are daytime biters. Some of them like to try to get inside the house. Some of them are outside. Some of them go miles away from where they hatched, and some of them just stay really, really close. Some of them are okay in standing water. Some of them are okay in running water. Some of them like to bite animals. Some like to bite humans. So again, there's all kinds of possibilities out there. And so different things work to maintain some mosquitoes that don't work to maintain others. When people are out there looking to see what mosquitoes are out there, there's lots of different groups that look at that and try to sort out what's going on. And there's a robust group of people in our local area that do that. But there's lots of ways to do that. One is that they'll set out traps that catch the mosquitoes, and they can test them to see which species you have and which diseases they may have inside of them. There also sometimes they'll ask the public to send in the mosquitoes that they've found, and they've done that here in Arizona from time to time, but I think it's been a while since they've last done that. And then they have these sentinel chickens. I don't know if you've ever heard of these guys before, but they have these flocks of chickens that are placed in strategic areas. We have some that are in Yuma. When I was in Iowa, they had some that were in Iowa, that basically they look at the chickens and see what diseases are these birds carrying that are being transmitted from the mosquitoes. Because a lot of these diseases, and we'll talk about West Nile in particular, are transmitted by birds. As the mosquitoes bite the birds move, and then it spreads to other places, back into the mosquitoes. So the major players are the Culex species, the Aedes species, and the Anopheles species. And we'll talk about these guys a little bit more in detail here, and then what they spread and the diseases too. So the Culex species tend to transmit things like West Nile and Zika. Again, a whole list of things that you've probably heard of, maybe some things that you haven't. These guys bite dawn to dusk. They're more particularly active in those early morning hours and the early evening hours. And so, you know, you can get bitten at any point in time, but I bet if you've been out at a soccer game in the evening time or something like that, that's when you start getting bitten. And it's often these guys that will do that. This is kind of just some maps to show the distribution of these types of species. And you can see that they really are throughout all of the United States. So not surprising that some of these diseases they transmit are also throughout the United States. And here on the right, you can see that they are for sure concentrated here in Maricopa County, but also in Yuma County and throughout Arizona. The Aedes species are vectors for things like chikungunya and yellow fever and Zika. These are also daytime biters that prefer morning and evening. They tend to stick around close to the breeding grounds. And so with yellow fever, it was easy to get rid of them because you could kind of fumigate the areas near where people were, but you didn't have to worry about the more tropical areas. Some of these other species go farther afield, and it's harder to get rid of them. And you can see here, there are two different major species here in the US. One is Aedes aegypti, and they tend to bite humans, and the other is albopictus, which tends to bite animals, but they can cross over and bite humans too. But again, you can see the distribution of where these species tend to be here in the US, and you could see that that would be a potential for some of these diseases to be. And then this just shows here in the yellow in Arizona, places where they're actively surveilling and finding these species as well. So the Anopheles species are the ones that transmit malaria. They tend to be, you know, human feeders. They tend to feed at night. That's why if you go to a malaria endemic area, you can bring a mosquito net with you and sleep under a mosquito net and decrease your chance of getting malaria. And the Anopheles hermsii is here present in Arizona, and that's why malaria can exist in Arizona. If you see this guy around, do you see this one up here in, yeah, I see it in Tucson all the time in the springtime. This is the crane fly. It's not a mosquito. Whenever it shows up, I look at it, I'm like, wow, that's the biggest bloodsucker I've ever seen. It actually doesn't suck blood. It doesn't affect humans. It doesn't transmit disease. I think it does cause problem with your lawns, is what I was reading. But they show up and they're not to be worried about as far as biting you and transmitting disease. So let's talk about the arboviruses. So, and that'll be mostly what we focus on as far as diseases go. There's lots of different viruses that mosquitoes can transmit. There's other things too, but the arboviruses are mostly what we'll deal with around here, and then some of the things that will show up. One of the main principles of this is that most people who get an arbovirus infection actually don't have any symptoms, and they do just fine. And a lot of these viruses have similar symptoms when you do. And so you get fevers, you get rash, you get myalgias, you get headaches, sound like kind of everything else, right? Like flu-like illness. And so a lot of people may not recognize that they have an arbovirus, and a lot of people may not think to look for an arbovirus. And most of the time you don't need to, and it doesn't matter. There are some of these viruses that have somewhat distinguishing features that if you have them, you might think, oh, maybe I'll go down the route to look for this specific one. So for example, chikungunya really tends to have an arthritis component. And we'll talk a little bit more about that here in a minute. And may have conjunctivitis, although a lot of them can do conjunctivitis too. But if you see conjunctivitis plus arthritis in someone who's been to an endemic area, or we think it's starting to creep into the community, you can think about chikungunya. Dengue tends to be much more severe than a lot of these other viruses, although all of them can cause severe disease. But you tend to see things like thrombocytopenia and hemorrhage. You can have retroorbital headache and pain throughout the body. They call it breakbone fever. If you have Zika, one of the things it can do is it could be transmitted sexually. Most of these other viruses don't. And so that's, one thing that's kind of distinguishing there, and it can cause birth defects. West Nile, this is really rare, but it can cause a flaccid paralysis. And so if you see somebody with a flaccid paralysis, West Nile should be on your differential, but it can look a little bit like polio and other things similar to it. And then Oropouche is this new virus. There's lots of different ways to pronounce it. That one also can cause birth defects. So if you see one of these things, you could think of, hey, maybe this is on my differential. So let's talk about West Nile, because we certainly have that. Basically, West Nile was discovered in the 1930s in Africa. That's why it's called West Nile. It didn't show up in the US until the late 90s, where they had an outbreak of encephalitis in Queens, New York. And then they figured out that it had finally hit the scene here on the US. It's transmitted by birds or by mosquitoes who bite birds, and then those birds go other places and then mosquitoes bite them. And so it's got this bird reservoir, and birds like to migrate and like to move. And so it very quickly moved all across the US. And you can kind of see here on this top, that blue is places where people and animals have gotten infected. And down below, you can again see where the Culex species exist here in the US. And so it's not surprising that West Nile really very quickly went throughout the rest of the US. It showed up here in Arizona in 2003, and it's basically been here to stay. And so because birds are affected, they often actually die because of the disease. And you may see bird die-offs in the community that are a harbinger to, hey, here maybe is going to be a new outbreak of West Nile disease in humans. So the other thing that can happen is it can get into the blood supply. So people are viremic with this, and then if you give it a transfusion, then it can get into a person and cause disease. And there are lots of reports of that early on before people figure that out. Since 2005, they've been screening the blood supply for this to try to make sure that that doesn't happen. And if there's really a high risk of outbreak, they don't just pool blood and look at it. They look at individually at each person. So in Arizona, you can see that there's kind of this baseline activity rate that's been happening. If we look at the 2023 data, which was the latest that I found at the time of preparing this, what they would do is they would take mosquito pools, so groups of mosquitoes that they'd sample, and check to see, did they have West Nile? And so certainly found a lot of West Nile in the different mosquito pools in the different counties. They saw it in the sentinel chicken flocks in Yuma, and then they certainly had several cases here in Arizona in people in lots of different counties, but Maricopa County being the one that had the highest burden of disease. You can see here in this spike that in 2021, there was a huge outbreak. And this was the biggest outbreak of West Nile disease in a single county in the United States up to this point in time. And I'm sure you guys probably know more about that since you live up here. But they had about 1,000 adults that had CNS disease. Remember, most of these viruses are asymptomatic, so you probably had a lot of people that had infection, didn't know it. And a lot of people probably had mild infection that didn't recognize it. It was these encephalitis cases that really brought this to people's attention. But they had about 1,000 people that had disease with encephalitis, and 100 of them died. And so a really high mortality rate when you think about it. But there weren't any pediatric cases that were described in that encephalitis, unless you know of some that snuck through that didn't get reported.
Yeah, cases, but they were never.
Yeah.
Right.
Yeah.
But clinical suspicion.
Yeah.
One of them is a kidney transplantation. And it's a clinical suspicion, but the testing.
And I keep trying to find West Nile in my encephalitis cases, and I haven't found it yet. My colleagues have found a case or two as time goes on. So it's one of those things to keep in the differential. It doesn't usually affect children severely, but it certainly can. So it's an RNA virus. We tend to see it in summer and fall. In fact, September is usually the peak month. So we're right in that time. Like I mentioned, most cases are asymptomatic, so a common theme. And kids, when they get infected, tend to be less severe than adults. When you do have symptomatic disease, like I mentioned, it's kind of the same old thing as a lot of things. You can have different rashes, and these are just some pictures of rashes that have been published in the literature, and you can see like, yeah, it's a rash. It doesn't look like anything to say, ah, this is West Nile. So most people aren't going to recognize that for what it is when it shows up. Obviously, you can get encephalitis, like we mentioned. And like I mentioned before, sometimes it can show up as the flaccid paralysis. So if you see that in a patient, especially if it's in mosquito season, think about West Nile. There's not any sort of antiviral treatment, unfortunately, for it. And if you're going to go looking for it, serology is usually the way to go. If you're looking for CNS disease, some people see that there's a PCR. The PCR really isn't useful with CNS disease, because by the time someone shows up with symptoms of encephalitis, the PCR is negative. And so if you're trying to sort out, does somebody have West Nile, especially encephalitis, you can do acute and convalescent serologies with antibody, both from blood and from CSF. So let's switch gears to a different virus. St. Louis encephalitis virus is another one that can be around here. So first figured it out in the 1930s in St. Louis when there's an outbreak of encephalitis. And again, similar theme, a lot of people who get it don't have any symptoms at all. And when they do get the symptoms, they're pretty similar. And kids can get infected and can have symptomatology. Sometimes they're more severe when they get it, but again, it's a pretty rare situation. Also, you diagnose it by serology, and again, there's no treatment available. So these are the Culex mosquitoes that are transmitting it, again, similar to West Nile. Most of the cases are found here in Maricopa County when they're reported. So not surprising, because that's where there's a big concentration of these mosquitoes. And we look at the 2023 data for the Arizona Department of Health Services. There were no human cases. They didn't have any positive sentinel chickens, but they did find them in the mosquitoes that were in the area. So it's still here. It's still lurking. It may show up. And then when you look back at 2022, there were a handful of human cases. So this is here. This will be there from time to time. When you order an arbovirus panel, this is often on that panel when you're getting serologies. And you can look, there's this vectorserve.org website that's interesting if you're ever bored. I think there's a paid version that I've never looked at, but you can do things like look at St. Louis encephalitis virus. And it's nice because you can pick the time frame of where you want to look. And so this is what I did for like a 20-year time frame, more or less. And here you can see the orange is where the mosquitoes tested positive. The purple is where the sentinel chicken flock was that tested positive. And the dark blue is going to be cases that were reported in humans. Now, you have to take cases in humans with a grain of salt as far as geography goes, because usually the way reporting works, it's where the case was diagnosed. It wasn't necessarily where the case was acquired. But certainly you can see that there is a concentration around areas where the mosquitoes and the chickens were testing positive. And this just shows that similar scenario happens throughout the US. And so there's lots of different places in the US where St. Louis encephalitis virus is around. Let's talk about Western equine, because it's also on that list of arbovirus panel that you get. It's also an RNA virus. This is also transmitted by Culex species. It also goes through birds. And since it's an equine virus, they actually used to have sentinel burrows instead of sentinel chickens back in the 1970s. And they could find it in rabbits and other things too. Human infection is pretty rare with Western equine. In fact, they used to go through these kind of epidemic cycles back in the 50s, 60s, and 70s, but we really haven't seen it here in the US since 1996. But there is an outbreak ongoing in Argentina at this point in time. And again, we have the potential for having it here. So it's something to be aware of, but it's not one that's around right now. And this just shows from that same website back about 15 years ago, it was still present in the mosquitoes, even though there weren't any human cases reported. And again, most of these things are asymptomatic, and so people may not recognize and may not test for it. Similar scenario as far as the symptoms when they do happen, similar scenario that you can do diagnostics with serology and PCR and biopsy of tissues in the right situation. And again, no treatments available. There is a vaccine for veterinarians and lab personnel and that sort of thing that's out there, but it's not widely used that I'm aware of. Chikungunya is another one to think about. So this means the word chikungunya means that which bends up, or to walk bent over in Makonde, if I'm pronouncing that right. But basically, it hurts so bad that you hunch over. And again, it's usually the joints. Remember, this is the one that causes the problems with the arthritis. And this is transmitted by the Aedes species. And it's the same mosquito that transmits dengue and Zika. This first was described in the 1700s in Africa, and then now it's been moving through ever since then. And so it showed up in the Caribbean in 2013, and now it's showing up in other places. You can see here on the map, The darker brown and the oranges are areas of higher concentration. You can see that it's really working its way through the Americas at this point in time. The good news is that if you do get infection, you have lifelong immunity. And so that is potentially helpful as far as a vaccine goes. Similar story, right? You have a high rate of asymptomatic infection. And then when you get the symptoms, they tend to be some of these other similar things. But again, the distinguishing thing with chikungunya is you tend to get arthritis. And that arthritis can actually last for weeks to months and sometimes a year and longer in some people. And so it can be really painful, really problematic for them. They can have conjunctivitis. They can get all kinds of different rashes. Sometimes you get oral ulcers like you see in the picture here. Sometimes you get a post-infectious hyperpigmentation rash as well. If you're trying to sort it out, you can do serology or PCR depending on what stage of the disease you're in. And again, there's no antiviral therapy that's available for it. The interesting thing is again, we've got these mosquitoes that transmit it here in the US, and there have been autochthonous cases, meaning cases that have been acquired and transmitted here in the US without any travel. And that's been described in Florida and Texas. And again, not surprising, we've got these mosquitoes. So we do have a potential for this coming into Arizona and establishing itself, but so far there haven't been any, locally transmitted cases that have been described in Arizona. There is a vaccine that's available now. It's a live attenuated vaccine. It causes viremia for about a week. And unfortunately, it's pretty decent as far as causing side effects. And so some people had severe enough arthritis from the vaccine that they actually had to be hospitalized. That was really quite rare to have the severe reaction, but a good 10% had a reaction that felt a little bit like the disease itself. The FDA has approved it for 18 and older, so we won't be using it in any of the pediatric patients at this point in time. And ACIP recommends it if you're going to go to a place with an active outbreak and you're over the age of 18, you can consider using it. If you're going to a place where it's been in the past and there's a potential for a new outbreak, you can consider it in certain high-risk situations. Let's talk about Zika. So you probably heard about Zika several years ago and the worry about traveling to a Zika endemic area. Zika is also transmitted by Aedes species. It's a daytime biter, usually dawn, dusk, and there are cases of sexual transmission associated with it. And so CDC has a whole list of things to do and not to do if you've been to an endemic area, especially if you're trying to conceive. Again, most of these are asymptomatic. And when you do get the symptoms, again, kind of similar scenario. But the claim to fame here that really brought this to our attention were these cases of birth defects that were happening in Brazil. And you can see here, these poor babies have the microcephaly, the arthrogryposis, the severe developmental delay associated things. There's also an association with Guillain-Barré as well. So also with this virus, that once you get infected, you have immunity for it, which can cause some trouble when trying to sort out and create a vaccine, because the people you want to try it out in, they're now already immune once it's come through and moved on. This will cross-react with dengue, both for test results and for potentially priming the immune system. We'll talk a little bit about that here in a minute, what that means. So again, if you're looking for it, usually serology. If you're later in the disease, you can do PCR earlier in disease process. Again, there's no treatment for it, and people are looking at getting vaccines up and going to see if that's a possibility. There have been local transmission of Zika here in the US. That was back in 2016 in Florida and Texas. Again, not surprising because that's where those mosquitoes are. And there has not been any locally transmitted case since 2018 in the US, and there's never been a case of local transmission here in Arizona, but certainly the possibility at some point in time, given the range of the mosquitoes. Talk dengue. So dengue is one that they don't really know for sure, but they think there might be an animal reservoir, but mostly it's a human disease. And it's really been increasing in frequency and since the last couple of decades. You can see this map on the right here that more and more people are getting exposed to dengue, and they estimate that there's about 400 million cases worldwide, and about half of the population of the world is at risk of getting infected with dengue. So it can certainly be a problem. You've probably heard about the health emergencies that have been declared in Puerto Rico as well as Brazil, where there are so many cases that it's really starting to overwhelm the health system there. It's a flavivirus. There are 4 types of dengue: dengue 1, 2, 3, and 4. And the interesting thing is that if you get infected with a type, you're immune to that type. So you get infected with type 1, you're now immune to type type 1. The problem is, and what they think is happening is that if you get the first infection, it then primes your immune system to overreact the next time you get a new infection with a different type. And that may cause more severe disease. It's not perfect. There's people who get their first infection, they have severe disease, and there's people who get a second infection and do just fine. But they think that something's happening with the immune system being primed. And that can be a problem if you got Zika, because remember, Zika can cross-react and that may prime you. And it can also be a problem with vaccines, and we'll talk about that here in a second. If you've had two types of infection with two different types, you may be protected against the next two. So again, the Aedes species, the interesting thing here is that the Aedes or the virus actually inhibits anticoagulation in the process of the mosquito feeding. And so instead of the mosquito getting one full blood meal from one person, it now has to bite multiple people. And now you can infect multiple people in that scenario. And then they have high-grade viremia. And then again, it's easier for those mosquitoes to get infected. And because of this and other viruses like this, the CDC actually recommends that if you've had a mosquito-borne illness, or you've traveled to a place where there's mosquito-borne illness, that once you get back, you should be using mosquito protection for about 3 weeks. That way you don't infect the mosquitoes in your area that then go and infect other people. So again, similar scenario, most of these are asymptomatic, but people can certainly get symptomatic and they can get quite ill. So it tends to go through 3 phases. You have the febrile phase, then you have the critical phase after the fever resolves, and then you have the convalescent phase. So mortality rate can be decent, 5%, but the key here is really managing the fluids, because that's where a lot of the problems are. So if you can really aggressively and correctly manage the fluids, you can really decrease the mortality rate. We'll talk about that here in a minute. So the febrile phase is the phase where people are symptomatic with the classic things that you can see right away. They may have rashes, they may have conjunctivitis. The fever lasts about a week. It can be pretty high. They don't feel so great. And they can really have lots of pain. This is why they call it breakbone fever, because it just hurts awful and it hurts everywhere. And then you can have some minor bleeding things here and there. You might have some conjunctival hemorrhage. You may have some mucosal bleeding, that sort of thing. And then, a bunch of other kind of non-specific things that can happen. Well, and one of the things you can do is, because you may have some thrombocytopenia, you can do the tourniquet test. You may have read about that before, but basically you inflate the cuff, you leave it about halfway for a few minutes, you relax it, and then you count the number of petechiae. And if you're in an endemic area and you do the tourniquet test and you've got a bunch of petechiae there, you probably have dengue. So after you go through that febrile phase, you hit the critical phase. And the critical phase is interesting because you're actually not having a fever anymore. So most diseases, your fever goes away, you're great, you're good to go. This is where things get really dodgy. So your fever goes away, you think all is well. Now you have about 48 hours and you may do just fine, and most people do, or you may get really, really sick. And so there's different things to look for. So about 1 in 20 people go into the bad form of the disease. They used to call it dengue hemorrhagic fever at that point in time, but they've actually gone away to that. And they're calling it severe dengue because not everybody gets hemorrhage. But basically what happens is you start leaking fluids out of your veins into different places. And so you start getting hemoconcentration, and so your creatinine goes up. And you start getting pleural effusions, ascites, all that kind of stuff that makes it difficult to manage. And then they can look really okay at first, and then suddenly they start developing shock because of these fluid shifts and other problems. And then you can get severe hemorrhage in different places and that sort of thing. Other things can happen around this time. You get myocarditis and encephalitis and things like that, but those are much more rare. So if you've got somebody in that 48 hours window, you really want to be watching to see what goes on. And you can start seeing some things that may suggest they're going to go in the wrong direction. So for example, if they have really bad abdominal pain that's persisting, or their vomiting is not getting better, they may go into the severe stage of the disease. If they're having trouble breathing, if they're having mucosal bleeding, if you see fluids accumulating in different places, if they've got hypotension and hepatomegaly, or hemoconcentration, these are all things that are suggesting that, fluids are going in the wrong place and things are going in the wrong direction here, and they're going to be really sick, and you're going to need to manage them really aggressively. Once you get past that, you go into the convalescent stage. And so this is where the fluids start getting reabsorbed, the hemodynamics improve, the labs start normalizing, and then often they'll get a rash. And this is a classic rash, this picture here, where it's that diffuse erythema, where you see these little white spots, and they call that islands of white on a red background. And so the people that I've talked to that take care of dengue say that once this shows up, you're usually good to go. I'm sure there's exceptions like anything, but usually this shows up, you're now moving into the convalescent phase. You're probably going to be okay. So when you're trying to sort out is dengue there, you can do it by serology, antigen, or PCR. So early in the disease process, when you're viremic, you can test for PCR. Antigen's the other way to go. And then as things kind of go on, you're looking at antigen and serology, depending on where you are. The CDC has a really nice pocket guide that I just learned about a little while ago. And it's really helpful for trying to manage these patients. And it really walks you through things step by step. I'll show you a picture of it here in a second. But again, the key is that you really want to manage the fluids. There's no antiviral treatment for it. And because there's bleeding risk, then you want to avoid things like NSAIDs and aspirin. So this is what the pocket guide looks like. Again, it lists, what those warning signs are. But the thing I really like is it tells you like mils per kilo of fluids per stage of what's going on, and then reassess. And so you say, okay, these are the fluids we're giving. We're going to reassess. Is it time to increase or is it time to decrease? And it's really in a short period of time. And so again, it's that key of giving enough fluids when they need it and backing them off when they don't. Because again, otherwise they may go in the places they don't belong and cause more trouble. There are some vaccines out there. One of them is Dengvaxia. This is approved by the FDA for use in a very narrow specific indication. So it's approved for someone who lives in an endemic area that is 9 to 16 years old and has evidence of prior dengue infection. And that's because of this issue of a first infection may prime you to have a worse infection. And what they found was that if someone had never had dengue before and they got this vaccine, if they did get dengue, they did a whole lot worse than if they had never been vaccinated before. And so there were some real problems with it. And so because of that, that's why in the US, it's recommended in that real narrow phase. If they give it to younger children, they tended to do worse. If they gave it to older people, it tended to do worse. In other parts of the world where they are using this vaccine, they've broadened out that indication to be up to 45 years of age. But here in the US, again, it's the endemic areas only. So this is not a travel vaccine from a US standpoint. So there's another vaccine that's out there, and I think that's probably the way people are going to go, because that doesn't seem to have that risk of causing that priming of the immune system and causing trouble with it. So we'll see. It's probably a little early, but from the data that's out there, it seems like it's not causing that problem. And I think I heard recently that the US isn't buying any more Dengvaxia, and so you may not ever hear about that again anyway. So we'll see how things go. This second one, though, is not available in the US at this point in time. They had applied for FDA approval, but then withdrew it because I think there were some questions and they hadn't answered them and decided it wasn't worth their while. But as time goes on, maybe they'll do it. But so far, there's not a ton of dengue in the continental United States. There are different territories and protectorates where it is, and obviously Puerto Rico. And so we'll see how things go as things change. So most people who get dengue are getting it somewhere else and bringing it back. But again, there is the risk of having it here in the US. There have been cases of local transmission and people that didn't travel, again, in the usual places, Texas and Florida, but there has been a couple of cases here in Arizona. So back in 2014, there was a big outbreak in Yuma. And what happened was right across the border in San Luis, Colorado, there was a big outbreak of dengue that then people traveled over, got infected, and came back infected. And so there were a lot of patients there. They tried looking around in the mosquito pools nearby to see if it was happening, if there's transmission that was happening locally here in the US, and they weren't able to find any evidence of it at that time. But in 2022, here in Maricopa County, there were a couple of cases. Person traveled down to Mexico, was only there for a few hours, comes back, has signs and symptoms consistent with dengue, gets tested. He actually has dengue type 3. And it turns out that type was not circulating in the area of Mexico where he went. So they really thought, hey, maybe this is being transmitted locally. So what did they do? They started looking at the mosquito pools nearby, and then they actually started testing asymptomatic people within a certain radius of his house. And they found that it actually was in the mosquitoes, and they found one other person who was asymptomatic that actually had dengue type 3 who had not traveled outside the US. So just evidence that it can happen, and it may happen here and it may happen again. Talk about malaria. So switching gears a little bit, as far as diseases go, and leave the viruses for a minute, because this is one that you're not probably going to see in someone that's going to acquire it locally, but it's a real problem in someone who comes back from travel, and you're going to want to pay attention to. So there's 5 different species. Plasmodium falciparum tends to be the most aggressive and most problematic one, but you can die from any one of these. It's transmitted by the Anopheles species, and like dengue, they think that half the world is basically half the world is at risk of getting infected with malaria at some point in time in their lives. And it's a major problem because they estimate that about 1 child dies every minute from malaria in the world. So it gets in, it causes cyclic fevers. It kind of goes to different parts of the body. You get it, the bite, it gets into the liver, it gets out of the liver, it gets into the blood, and it cycles through the blood cells, and the blood cells lyse. And the timing of the fevers tends to coincide with the timing of the red cell lysis, and that timing tends to be different depending on which species you have. It can get into most places and cause problems in all kinds of organ system. And when you look at who's at the highest risk for severe disease and death, it tends to be people who are infected with falciparum. And then if you've had your first infection, you tend to be more likely to have severe disease. And then, the typical at-risk groups, children, the medically frail, immunocompromised, pregnant people, and that sort of thing. If you're trying to sort out if someone has malaria, you can do a couple of things. One is the rapid malaria test. And this is nice because you can get a result back within, I think it's like 15 minutes. But basically, it's got these little bands, and it tells you if you have falciparum or if you have a non-falciparum species or no malaria at all. Like anything, nothing's perfect, but it works pretty well. And you want to know whether you have falciparum or not, because again, falciparum tends to be the one that's much more aggressive. And so if you have somebody who's got a positive falciparum, you're going to be much more aggressive with working them up and treating them, as opposed to someone who's really well appearing and say maybe has Vivax or a Valley or one of these other ones. Again, you got to take them all seriously, but you may have some wiggle room depending on what's going on. And then you can get your thick and your thin smears. And those take a little more time depending on what your resources are, because it takes more training to look at it and sort out what you've got. But what you can do is the person who knows what they're doing can look at these and see what's the morphology here. So you can see here in this one, you've got multiple ring forms in one cell, and they have kind of the headphone appearance. This is classic for falciparum. And so you see that, you've got falciparum, you're going to be more aggressive. The other thing you can look at is how many of these red cells are infected. And that's an issue because those are soon to be lysed red cells, and the problems that are going to be associated with that. And you can get your percent parasitemia, and that's important because the higher percent parasitemia, potentially the higher severity of the disease that you're going to have, and it's also going to be affecting what you're going to be using to treat them. Sometimes you'll see this on the CBC. I've had several over the last few years where they got a CBC with diff, and a smart lab tech said, hey, there's something in there. I think you should order a malaria smear. Hint, hint, it's malaria, but I can't call it officially. And so now suddenly they're coming to see us, and we're treating them up. When you're trying to sort out how to prevent malaria with antimicrobials and how you're going to treat it, there are lots of resources out there. And certainly you can call your friendly neighborhood ID doctors, but there's actually also a CDC hotline. And I've called them a few times with these complicated cases that we get. They're really helpful. And so don't forget that if you're dealing with somebody, especially in the middle of the night. When you're trying to sort out what's going on with malaria, you really need to get the story of where they've been, what they've been doing, because different species of malaria are in different areas of the world. And some places will have falciparum, some won't. Some will have chloroquine resistance and some won't. And so some of them can cause relapse. So for example, Vivax and Ovali have those hypnozoites that hang out in the liver, and they can show up months to years later after you've gotten your original treatment, and you can relapse. And then you have to think about like G6PD status, because what you use to treat the hypnozoites can cause trouble with that. So you look at all those things and decide, what does it mean? What am I going to do, either in the prevention stage before they travel somewhere, or when they're infected when they come back? And then again, you look at what is the potential for severe disease here, and what are you going to do about it? So remember, falciparum has the highest risk of severe disease, and especially your first infection. And there's this group of people called VFR. It's visiting friends and relatives. And so you have people that grew up in an area with malaria. And what happens is when you get malaria over and over again, you tend to start becoming a little bit resistant to it and don't get as severely ill a lot of the time. And so people that grew up in malaria endemic areas, they just got a fever every once in a while. It was no big deal, and they got over it. And then maybe they went to the doctor and they took their antimalarial and they're okay. Well, they leave the country and go live somewhere else for a few years, and they lose that protection. And they don't recognize that that's a risk. They go back to visit, and they don't think to take anti-malarial prophylaxis, they get infected and they come back and they die in country or come back and die or have severe sequelae because of it. So you look at kind of what's available, what your options are, and all that kind of thing. We'll talk a little bit about that. So when you're treating people who have malaria disease, again, you look at, do you have falciparum and do you have chloroquine resistance? And so if you don't have chloroquine resistance or you have a non-falciparum species, then you can use chloroquine or hydroxychloroquine. Any of the other antimalarials will work. And then again, if you're trying to sort out, do they have Vivax or Avali, you want to get your G6PD to decide if they have that, because you can cause problems with primaquine when you're trying to treat those hypnozoites. If you've got chloroquine resistant falciparum, but you're not severe, you can try the oral antimalarials, and those work really quite well. If you have severe malaria, then you're going to do things that are different. And severe malaria are things that have end organ damage. So you've got impaired mentation, you've got AKI, ARDS, things like jaundice, that sort of thing. If you've got DIC, you know, that's an option for severe malaria. And then if you've got parasitemia greater than 5%, those are all signs that this is severe. We're going to be more aggressive. And so this is where you do the IV form of therapy. And around here, it's artesunate. And often you have to get that shipped in from somewhere. And so if you've got somebody who has severe disease that you want to do an IV, but it's going to take you 12 to 24 hours to get it there, you can drop it in an NG tube and use one of the oral antimalarials in the meantime. Then usually you treat them up. They often get better. They sometimes don't. But when they are getting better, then you often switch to an oral regimen to kind of finish out. And these regimens are well described in the literature and recommendations. And again, the hotline can help you too, and your friendly neighborhood ID doctors as well. So when you're trying to figure out what to do to prevent people from getting malaria, again, there's lots of different options, and you're going to look where they're going, what kind of malaria is there, what are they willing to take? Because some of these regimens you have to take daily. Some of them you take once a week. Some of them have different side effects. Some of them are more expensive than others. Some of them you have to take a couple of weeks or a few weeks before going. Some of them you have to keep taking several weeks. Most of them you have to keep taking after, but some of them are a few days. Some of them are several weeks. And so there's lots of different options out there. And so the CDC website really has a lot of good information if you don't have other resources. And so you can look up the country, you can look up the cities where they're going and see, is there a risk of this? And, you know, what are the options to treat? And these are just different medications. We won't go through them because you probably won't have to know them most of the time. And I always look them up anyway. And so there's different options that are out there. Some of you may recognize, some you may not. There are some malaria vaccines out there. They're only specific for falciparum. And if you look at this first one, it only has 39% efficacy in children, which is really sad that it's so low. But if you think about it, remember, one child is dying every minute from malaria in the world. Anything is a potential useful tool in your armamentarium against malaria. So it's better than nothing. It'd be nice if it were better. There's a newer one out that may have better efficacy, but it may just be they don't have enough data to show that one way or another. People are continuing to work on this, but there's a long way to go still. So we'll talk about Oropouche virus real quick. You may have heard about that. This is a newer to us virus. I hadn't heard about it until about probably 3 months ago. It's an RNA virus, and you may have heard about it because the CDC put out a health alert network alert, and because there's a current outbreak going on in Cuba. It's basically been known to have been in the Amazon basin for quite some time, and it's also transmitted by Culex mosquitoes, but it's actually probably more transmitted by the no-see-ums, these midges. And so just included it because it may be something you hear about as time goes on. It's got the same story as a lot of things, although it's a little bit different in that you can have symptoms, get over it, and then the symptoms may come back over and over again over the course of days to weeks. I don't know if they're viremic during that time or not, but they certainly can have recurrence of symptoms. And there have been cases of vertical transmission and birth defects similar to Zika. Similar story, there's no antiviral therapy. Because it happens in a lot of the dengue areas, you avoid the NSAIDs until you can figure out what you have. And right now, they're recommending against travel to Cuba if you're pregnant and don't absolutely have to go, and then you can kind of do shared decision-making for the other places. Similar scenario of serologies and PCRs. These are specialty tests. If you're worried about it, you can talk to your local health department who will coordinate with the CDC for testing. So when we're trying to figure out how to prevent mosquito infection, again, remember there's water everywhere. So if you can manage your water sources, things like your pools emptying, your different areas where water can accumulate, and paying attention to your environment can really decrease the amount of mosquitoes that are around. And then if you have screens on your windows, then it may be harder for these mosquitoes to get in. And that's one of the thoughts that people have, why maybe the people in the US tend not to get as many infections compared to some of these other places, even across the border, because we love our air conditioning and keep screens on our windows. When you're looking at using mosquito repellents, you can look at the CDC. The EPA has information on which mosquito repellents to use, and the AAP also has different things that they say. If, like I mentioned, if you travel to an endemic area and you come back, use mosquito repellent for another 3 weeks, especially if you've had an infection while you were there, to try to decrease that virus or parasite from getting into the mosquito pool. The general principles as far as mosquito repellents go: the higher the concentration, the longer lasting the protection, the higher the risk of toxicity. And in kids, we want to avoid their hands in their mouth because of moving their hands in their mouth and potentially getting systemic absorption of chemicals that could be problematic. If you're going to spray, use it in a well-ventilated area so you're not breathing in, and a lot of the common sense things. In kids, little babies, there is a concern again, could there be some more absorption? They haven't been able to show that with most of these scenarios, but there is the discussion: if you've got a little baby, you may consider alternative things than using a mosquito repellent, using long sleeves, putting a net over the baby seat, things like that. And then if you are using it, then wash your skin as you come back indoors. We don't really have a whole lot of time to talk about the different repellents that's out there. You can have access to the slides, but there's a lot of good information out there. DEET, they used to say, don't use under the age of 2. There is now, the EPA says specifically there's not an age limit of when you should or shouldn't use it. And the AAP has been kind of moderating what they say as time goes on in their messaging, saying you can, but again, use caution, use judgment in these little kiddos. But there's different, chemicals that are out there that are available to be used. One that you may see is this oil of lemon eucalyptus. When it's in a combo, it is EPA approved. If it's by itself, it's never been proven to actually prevent mosquito bites. And so they say don't necessarily use it in that sense. They do say with this one to avoid under the age of 3 because of the potential for allergic reactions at that age. You can apply permethrin to clothing. Remember, this is, you've probably used permethrin in the past for different infestations and things like that on the skin. But when you're trying to prevent things like mosquitoes and ticks, you can use it on your clothing. And so that's an option too. And there are certain types of clothing that's out there that you can buy that's already permethrin impregnated and it's supposed to last a certain amount of washes. And I don't know all the details there. There are these things out there like the citronella and the botanical oils. They don't know for sure if they work. They're not officially recommended. And then these spatial repellents that you can buy, they're not officially recommended because they don't know if they do anything to truly prevent mosquito-borne illness. So these, diseases are out there. They are in our own backyard. They could potentially be brought in from travelers. So think about them in the right situations. Think about prevention in your homes and your areas around you, and think about, wearing mosquito repellent in the right situation. And if someone is going to go travel somewhere and it, talk to them about things they can do to prevent infection, including look up to see, is there malaria in that area and which medication would work. There are travel clinics out there. A lot of them don't do great with kids, but some of them do. But it's a real need in the community that's under met need. So obviously ask for help from your friendly neighborhood ID doctors. You've got the CDC hotline as well for malaria. And there's a lot of other CDC experts that are out there to help you with certain diseases that are there. So anyway, we'll end there and see if there's any questions.
My question is one, just in terms of you guys from the area. One of the challenges that we have here is the rapid testing, which will work my next now. But also the GC-SPB test and time it takes to get it back, especially when patients that it's probably going to be pilots, but that based on the country of origin, and you're just waiting for that GC test to come back to decide that it what you can use it. And most of the times, obviously, the population of patients that we see with 5X there are some social challenges that you want to make sure that you're sending them out with the So are you guys, what's your kind of process? in switching to that?
So for those online, the question was about malaria with rapid testing and availability of the testing, as well as things like G6PD, and then trying to have that in a timely fashion to let people go, knowing there's a social side. I don't have a great answer. You're right. It's a struggle. We just got the rapid testing in-house like 6 months ago. So we were struggling with that. We'd have to send it up here, and I wasn't getting my testing back in the first place until 24 to 48 hours sometimes. And so we just got that in-house. Do you guys have the Binax now in-house?
So plus or minus,
Yeah.
working on it, but it's easy for us because we can send it to St. Joe.
Yeah, so you'll get it back in a really fast.
So,
Yeah. So
St. Joe's, this is just down the street.
yeah.
It's more the challenge is usually G6.
Yeah, so similar thing for us. The G6PD comes back several days later. The upside is if you do have good contact with the person, you can get them Primaquine, and usually they're not going to relapse right away, and you have some time to deal with that. But you're right. The bad news is if they go away and you're never going to see them again, then it's hard to get that. And yeah, it's a problem. And I don't have a good answer for it. It's especially hard in folks. I bet you get the same thing we do, where people come in, they're in border patrol custody. You never know if you're ever going to see it or hear from them again once they leave the hospital. And so sometimes I'll keep people extra just for certain things to make sure we have it. And it's a bummer, but sometimes that's all you can do. Any other questions?
I can actually make another comment.
All right.
So I had dengue fever in 2007.
Oh, yeah?
The great bone fever term is totally understandable.
Yeah. Dengue sounds miserable.
Yeah, it is. Not a joke.
All right. Is there anything online for question wise? I always forget to look.
My question has to do with how to get any credit for this.
All right, good. Problem solved. You'll tell them. All right. Well, thank you,
Dr.
everybody.
Price, would you mind getting to the next slide? That way people can do the code. You-
No, I'm up here. I can. Oh, okay. I'm not on the schedule anymore. Just kind of filling it. Yeah. Not even. I'm not just. He was a pharmaceutical. Now it's a drug group for 17 years.
Regarding that now, or is the day to start getting? Yeah, that's fun. So like, running it out. I'm sure we'll. Yeah. That's what I thought.